Welcome back to Not So Complicated, and this is our third and final session of renal pathology. We have completed our general principles and then our respiratory pathology, cardiovascular pathology, hematology and oncology, gastroenterology, hepatobiliary system, and now today will be completing our renal pathology, right? So we have left our renal tumors, and this is just a very short session. This is just 2 pages of USMLE first aid step 1 line by line. Let's begin from the renal cell carcinoma, right? So what is actually renal cell carcinoma? Renal cell carcinoma, they are also polygonal clear cells, as you can see in the figure right here. Polygonal clear cells, you can see these polygonal clear cells are typical features of renal cell carcinoma, and what actually happens is that these cells will deposit glycogen, and that will lead to increase in cytoplasmic content of the cell, and thus they are clear in appearance in histology in H&E stain, right? So they are usually filled with accumulated lipids and carbohydrate obviously glycogen. They are often golden yellow in color, and in gross pathology due to the increased lipid content, here you can see yellowish color in gross pathology, right? Often golden yellow color right here, and it originates from PCT, that is proximal convoluted tubule, that invades renal vein, may develop varicocele if it is left-sided, and also inferior vena cava that will from hematogenesis spread will metastasize to the lungs, and also bone and liver, most commonly to the lungs, but also in bone and liver they will metastasize. So invasion of renal vein is very common in renal cell carcinoma. You have to remember this high yield point, renal vein. Renal cell carcinoma invades renal vein, right? So it manifests as flank pain, palpable mass, and hematuria, which is classic triad. These are classic triad: flank pain, palpable mass, and hematuria. This is classic triad of renal cell carcinoma. As well as anemia can be present, secondary polycythemia, because there is anemia. That anemia will be sensed by the cells of kidney, right? So they will secrete erythropoietin, that is EPO, and that EPO will lead to increase in synthesis of RBCs, causing secondary polycythemia, and also fever and weight loss can be there. The treatment is surgery or ablation for localized disease, and immunotherapy, that is ipilimumab or targeted therapy for metastatic disease, which is rarely curative, and it is resistant to radiation and chemotherapy. This is very high yield point right here. Renal cell carcinoma is resistant to radiation and chemotherapy. Most common primary renal malignancy is like this is the case where there is most common primary renal malignancy, and most common in males of age 50 to 70 years, right? So increased incidence with tobacco smoking and obesity is there found, and associated with paraneoplastic syndromes. Paraneoplastic syndromes are actually those kind of syndromes, like those spectrum of diseases that arise, those endocrinal dysfunction that arise in the presence of tumor but are completely unrelated to the tumor. So that are paraneoplastic syndromes. Example, PDS, RP, or ectopic EPO, or SCTS, and Renal. So PER, paraneoplastic, paraneoplastic, you can remember like that. So PTHRP, obviously parathyroid hormone receptor protein, that will lead to hypercalcemia, and ectopic EPO will lead to secondary polycythemia, SCTS will lead to Cushing's disease, and Renal will lead to increase in angiotensin 2 that causes hyperfiltration or increased in glomerular filtration, right? So clear cell is the most common subtype of renal cell carcinoma with gene deletion on chromosome 3, and also sporadic or inherited is von Hippel-Lindau syndrome, BHL disease, right? So RCC has 3 letters, also chromosome 3, and associated with BHL, that is von Hippel-Lindau disease, also which has 3 letters right here. This you can see in MRI scan right here. You can see the clear demarcation of this tumor infiltrating the kidneys, right? So this is renal cell carcinoma for you. And now we will talk about renal oncocytoma. It is benign epithelial cell tumor. Benign epithelial cell tumor. You can write here C. So what is different between the benign tumor and malignant tumor? We have talked about it in our general principles neoplasia, right? So the classic difference is that the benign tumor is not infiltrative in nature and it has a very clear demarcated lining, and it arises from collecting ducts. The renal cell carcinoma arises from proximal convoluted tubule, that is PCT, but renal oncocytoma arises from collecting ducts, that is CD, right? Here. And also red arrow in here. Like this is the region where it arose, right? So points to well circumscribed mass. Yellow arrow points to central scar right here. This is the gross pathology, and large eosinophilic cells with abundant mitochondria without perinuclear clearing are there. Okay. Here you can see, right? Eosinophilic cells and versus chromophobe renal cell carcinoma. So it presents with painless hematuria, flank pain, and abdominal mass, often resected to exclude malignancy. Right? So this is a benign epithelial cell tumor. Let's talk about nephroblastoma. Nephroblastoma is also called Wilm's tumor. This is the tumor of childhood and the most common renal malignancy of early childhood, as I have talked earlier, and it is most commonly found in the people with age 2 to 4. It contains embryonic glomerular structures most often present with large palpable unilateral flank mass. Large palpable unilateral flank mass. You can see this is a very large tumor right here, right? So also it may be present with or without hematuria and also possible hypertension. It can be associated with loss of function mutations of tumor suppressor genes WT1 and WT2. We have talked about how we remember about tumor suppressor genes and oncogenes. I have made a song for you, and that is in my channel. So if you are new here, you can look at that. And also on chromosome 11, so Wilm's tumor, WII, that is 11MS Wilm's tumor, right? You can remember like that. And it may be a part of several syndromes like Weger complex, where there is Wilm's tumor, aniridia, that is absence of iris, aniridia, and genitourinary malformations, or range of developmental delays, WT1 deletion, right? So it can be a part of Weger complex or Dennis-Drash syndrome or Beckwith-Wiedemann syndrome. So in Dennis-Drash syndrome, what happens is there is Wilm's tumor and also diffuse mesangial sclerosis, that is early onset nephrotic syndrome is there. And also dysgenesis of gonads can be present, causing male pseudohermaphroditism, and also WT1 mutation is the reason. And in Beckwith-Wiedemann syndrome, there is Wilm's tumor, increase in organ size like organomegaly, and tongue enlargement is there, which we call macroglossia. Tongue enlargement, which we call macroglossia, and hemihyperplasia can be present, that is imprinting defect causing genetic overexpression associated with WT2 mutation. WT2, this time it is WT2 mutation, and in these two complexes or syndrome, it was WT1 mutation, and also omphalocele can be present, right? So let's talk about urothelial carcinoma of the bladder. In urothelial carcinoma of the bladder, it is also called transitional cell carcinoma. You cannot be confused in these two terms, urothelial carcinoma or transitional cell carcinoma. Let's talk about so it is most common tumor of urinary tract system, can occur in renal calyces, renal pelvis, ureters, and bladder. It can occur in any of these portions, right? So here you can see this is a tumor, you can see, right? And also it can be suggested by painless hematuria, that is no casts, and also here you see the wild infiltration of cells, right? These ducts are totally obliterated. The tubules are totally obliterated by this infiltration of cells. Wild mutation is there, right? So associated with problems in your pee sac, right? And tobacco smoking, aromatic amines found in dyes, and cyclophosphamide can be the associated causes here. And let's talk about squamous cell carcinoma of the bladder. Squamous cell carcinoma of the bladder, it is chronic irritation of urinary bladder that will lead to squamous metaplasia. That metaplasia can lead to dysphagia and thus squamous cell carcinoma. The risk factors include 4 S's. One is cystosoma hematobium infection. This is very important thing. A patient with a previous history of cystosoma hematobium infection can present with squamous cell carcinoma in a very long term. And also, chronic cystitis can occur, smoking, and chronic nephrolithiasis, that is stones. So 4 S's are 4S. So 4 S's have a high propensity to develop squamous cell carcinoma of the bladder, right? So it presents with painless hematuria and also no casts. So that is how we complete our renal pathology. Thank you for staying with me if you are still here, and we will talk about endocrine pathology in our next session, and we'll be completing that in different sessions that too. Okay, subscribe for daily updates, and also 5 minutes 5 high yield drugs, 1 minute 1 high yield concept series. You can stay with us. Thank you.